Welcome to the Therapy Show podcast. I'm your host, Lisa Mustard. In each episode, I interview a seasoned and knowledgeable talk therapist from the counseling world to glean valuable insights, techniques, and tools that you can apply to your practice and your life. And if you're considering a career in the counseling field or just want to hear about what it's like to be a talk therapist, then this is the podcast for you. 2 episodes are now approved for continuing education contact hours. Episode 2, an overview of eating disorders and treatment, and Episode 3, using meditation and Ayurvedic life coaching as tools in your practice. And we are working behind the scenes to get the website finished so you can purchase the courses. But in the meantime, head over to my website, lisamustard.com, to grab your discount on your very first course purchase. That's lisamustard.com, and you'll see a sign-up box on the homepage. Today's episode is on binge eating disorder. Brandi Stalzer of the Eating Recovery Center gives us an overview of the guidelines, helps us understand treatment options, and shares a variety of evidence-based approaches to treating eating disorders. She is the clinical manager for the Eating Recovery Center of the Carolinas, where her role focuses on providing clinical direction to staff on cases and the milieu for partial hospitalization and intensive outpatient levels of care. Prior to working at ERC, she has worked in the eating disorder field in Omaha, Nebraska, and a variety of aspects, including direct care, therapy, and supervision. She carried on the mission of advocating for those struggling with eating disorders in her volunteer life by serving as the website chair for the Nebraska Eating Disorder Network, and she currently works with college-age women on body image initiatives. She is knowledgeable in a variety of evidence-based approaches, including enhanced cognitive behavioral therapy, acceptance and commitment therapy, and dialectical behavior therapy. We hope you enjoyed today's episode. Well, hey, everybody. Welcome to today's episode of The Therapy Show. I'm your host, Lisa Mustard, and I have today's guest, Brandi Stalzer, here for a really interesting discussion about eating disorders, eating disorder treatment, binge eating disorder. We're really going to get into the weeds today about treatment, about what this disorder looks like, how to help your patients, your clients move through the process of recovery when it comes to eating disorders. So welcome to the show, Brandi. I'm so excited to have you here.
Hi there. I'm happy to be here as well.
Yeah, this is fun. This is so fun. Okay, so Brandi, can you tell the listeners a little bit about who you are and where you work?
Yeah, so as you mentioned, my name is Brandi Stalzer. I'm the clinical director here in Greenville, South Carolina, of the Eating Recovery Center of the Carolinas. And I came here about a year ago and came on as the director here. And my role really is to kind of shape the program, shape our clinicians that are working on the various cases, and then just kind of be that go-between with some of our upper management as well. I have worked in the eating disorder field for quite a few years, and I moved from the Midwest. And when I was working in the Midwest, I was also working in that population. And so down here, I decided to kind of take on this role down in the South just because I worked quite a bit with ERC up in their headquarters in Denver, and just really came to love this organization. And so I'm finding the same down here. It's a great company and a great staff that I'm working with.
Well, that's awesome. And welcome to South Carolina. I know you and I connected most recently at the Low Country Mental Health Conference, and I was super excited to learn about your center. I honestly didn't even know that you guys existed. So you are up in Greenville, which is one of my favorite cities in South Carolina. So I'm jealous. I love Greenville. In fact, now I have another reason to come up and visit, and we can go to lunch and all that good stuff. So yeah, Greenville is just a great, great town. I love to ask the question to all of my guests: how did you decide to become a talk therapist?
Yes, my career journey was actually I didn't start out getting a degree in psychology or anything kind of related to that. Actually, my career, I started in marketing. And in some of my first jobs that I've had in the marketing field, I quickly learned this isn't the field for me. And right around the time that I was finding that out, that was probably about the time that the recession was going on, and other, marketing jobs that were available just weren't out there. So I decided to make a complete change altogether and start working in the mental health field. And once I got there, it was like, oh, this is what I'm supposed to be doing. This feels right. And
Right.
so the natural step when you're working in the mental health field is maybe to go on to counseling next. And so I obtained a degree in counseling. And then from there, my internship experience was with an eating disorder program up in Omaha, Nebraska.
Hmm.
And so I stayed on with them and really just became invested in that population. I'm passionate about what I do. I love it, makes sense. When you're in a field that you're working in and it just kind of feels right in your gut, you're in the right place. And that's kind of how I feel with this group of clients that we work with.
Well, that's phenomenal. I love to hear that. The past couple weeks, I've interviewed some really amazing clinicians, and you're right. And I think that really is what separates and I don't say good therapist, but someone who's passionate about their work. It's like they feel it in their gut. They can't imagine, being in another space. And I think
Yeah.
it's really cool when you can find that. So I'm really glad that you are doing the work that you do because, I remember walking up to you guys at your table and you were just so welcoming and warm. And I was like, these people are just phenomenal. So I'm really glad that you're in this field. And my background's in marketing too, which I think is kind of
Oh,
cool.
I don't know. I feel like you learn in the marketing field, you learn a lot about building relationships and, also building those relationships for businesses. And so it makes a little bit of sense. And in essence, I'm kind of using my degree just in some regards, being a director of the program,
Oh yeah.
but it's a natural kind of change to go into the counseling world from that degree.
Well, for sure. Can you talk a little bit about the ERC and,
Yeah.
can you share with us the company and where you guys are located?
So, Eating Recovery Center of the Carolinas, we're located, like I mentioned, in Greenville, kind of just off Pelham Road,
Mhm.
Pelham and the interstate. ERC is a wider organization than just our location, though. So, we're headquartered out of Denver, Colorado. It's where it got its start about 11 years ago. And during its start there, they really focused at the beginning, just making sure that there were higher levels of care for eating disorders, like the inpatient level of care and residential level of care. And as ERC expanded throughout the last few years, they've really tried to make sure that they have all levels of care throughout their agency. So we have partial hospitalization and intensive outpatient here in Greenville, but ERC is one of the few eating disorder treatment facilities that has that entire continuum of care.
Okay.
Anywhere from acute services, so that would be like ICU level of care,
Mhm.
all the way down to IOP. We intentionally don't do outpatient services because we really do find that providers are a part of our mission statement, and we don't want to be competing with them, and we want to be a resource for them. We kind of see ourselves as holding their patients and making sure they're stabilized, but we're not necessarily the provider. They're
I
the
gotcha.
provider.
I gotcha. That's a nice way to work with, clinicians and providers. I like that, the way you phrase that. So what are you going to cover for us today? What's our topic?
Yeah, so in an earlier segment on eating disorders that you've done, you guys did a really great job of conceptualizing and understanding like the diagnostic criteria of eating disorders. So I thought kind of the next step of really getting familiar with eating disorders would be to understand what those levels of care really look like. I know that it's easy for us clinicians to be working with a patient and kind of forget that they're not providers and they just don't understand treatment sometimes. And so sometimes we really do have to just like educate them on like this is what it's going to look like and what you're going to get and why you might need that higher level of care or why you might need a lower level of care. And then in addition to that, I wanted to touch base a little bit on binge eating disorder because they are not really well covered in the APA level of care guidelines because those guidelines were developed prior to the most recent change in the DSM. And so I want to touch base on ERC has developed some level of care guidelines for binge eating disorder, but also to talk a little bit about the diagnosis as well. And then I know that providers are always asking like, what treatment intervention should I be using? What does treatment look like with eating disorders? And so I wanted to touch base a little bit on what types of interventions you might use and what's most evidence-based with this population.
Okay, awesome. Well, I'm excited to learn. So yeah, feel free to just jump right in. Where would you like to start?
Okay, so let's start with the different levels of care. I'll kind of just go in that order, I guess.
Okay.
So, and let me start with the lowest level of care because sometimes IOP gets a little bit forgotten because it is less intensive. And I know, I've also kind of worked in the outpatient field as well with eating disorders. And sometimes it feels like you're on an island a little bit, like trying to coordinate care with people that aren't in your office setting. And sometimes we forget that IOP is out there. So IOP is intended to be still outpatient level of care. It's a little bit more intensive and it does provide some support around meal times. But because it's not quite as intensive as partial level of care, a person who is in the IOP level of care, they really should have the ability to self-manage most of their meals and snacks for the most part.
Okay.
And at the same time, they're still demonstrating some difficulty in doing that, and that's why they're needing some more intensive type services. At the IOP level of care, someone really should be medically stable. And so at ERC, you would notice that patients aren't really getting a whole lot of medical management at the IOP level of care because it shouldn't be needed. Occasionally, we'll see patients that maybe are kind of in between. Maybe insurance denied them before we really wanted them to be. Maybe there was just barriers to doing a higher level of care. And in those cases, of course, we're going to provide some medical management. But for the most part, IOP, there's not a lot of coordination with a nurse. We might be coordinating with their outpatient PCP. And the intensity of individual therapy and nutrition services is a little less intense as well. At the PHP level of care, at ERC at least, it is 7 days a week. It's 8 hours a day. And so the thing that really kind of makes it different from IOP is that a patient at that point, they're really struggling to independently get those meals and snacks in on their own.
Gotcha.
Or in the case of those that have more loss of control symptoms, they're struggling to implement their meal plan independently. They might still be getting meals and snacks in, but they might be engaging in behaviors and they're not able to independently stop some of it. And the same is true also for someone who maybe has a diagnosis of bulimia nervosa, where they are engaging in purging type behaviors or other compensatory behaviors. They're really struggling independently to stop those behaviors on their own.
Okay.
So PHP, you're starting to see that there's a little bit more medical necessity to have support and monitoring throughout the day. And the thing that differentiates PHP from RES then is that at RES, especially in the restricting type disorders, they're still medically stable, but the amount of weight that might need to be restored or the amount of behaviors that are occurring really do need a lot of medical supervision around it. It's possible that somebody at the residential level of care might be on a tube feeding, and that wouldn't be appropriate at a PHP level of care because really they should be fairly medically stable as well.
Okay.
And at residential, they might be putting on, or they might be restoring nutritionally a lot more rapidly than you would at a PHP level of care. And then in inpatient, at that point, they probably aren't very medically stable. So there might be symptoms that you're seeing, such as a very low heart rate, their blood pressure is really low. Maybe there's huge drops in their blood pressure when they go from a sitting position to a standing position. You might be seeing some differences in their lab work that are kind of scary. And so overall, someone that's an inpatient, they are really, the work that they're doing at that level of care is just trying to stabilize, medically speaking.
Gotcha.
And then the acute level of care, again, this is more of like an ICU type of service. And so people might be there for, a very short period of time. A lot of times the patients that are at that level of care, they're not even medically stable enough to be life flighted into to the services. And so sometimes they might be having to use something like an ambulance to get to services, which can be really difficult. I think the good thing about Eating Recovery Center is that we have the departments and we have staffing available to really help patients understand their medical benefits, to really understand the process of having to use their medical benefits for things like travel, to just walk them through that process if they're having to move different levels of care. So generally speaking, when we're talking about eating disorders, that's what the different levels of care are going to look like. In regards to the guidelines for determining where a patient should be in treatment, there's quite a few different factors that we use. So at Eating Recovery Center, we are pretty consistent with the APA guidelines that were developed. I believe they were first developed in 2005, and then they were revised again and copyrighted in 2010, be updated. And one of the main things that they look at is that medical status. So again, if somebody is medically stable, we're probably looking at outpatient, IOP, partial hospitalization. If they are not stable, we really are probably not even going to look at those lower levels of care. Suicidality is another thing that we look at when it comes to where they need to be. And if suicidality is present to the point where they have intent to engage in a plan, they have a plan developed, inpatient is what we're going to recommend, but we would probably actually recommend more psychiatric inpatient than eating disorder inpatient at that point. And if suicidality is present at some of the lower levels of care, the intensity of that and how much intent they have, how much of a plan they've developed, how much access they have to means, we would really look at as well to determine how much support needs to be around them to manage that aspect of what they're going through as well. Weight is a part of the APA guidelines, although it's a little bit of a difficult conversation for us to have with patients. We really try not to focus so much on weight when they're in treatment, although of course it's part of the treatment for some of our patients. So generally speaking, if somebody is 85% of their expected body weight, if they're above that, outpatient probably would be pretty doable. If they're below 80%, we might be looking at intensive outpatient at that point. If they're also below intensive outpatient, but maybe needing a lot more support, PHP would probably be a good setting for them. And then generally speaking, if they're largely below that, we would be looking at other levels of care. So the weight criteria is part of those guidelines. There's other guidelines as well, such as the ability to be able to, the structure that's needed for eating around meals, and the ability to control compulsive exercising and any purging behaviors that are present. And so generally speaking, if somebody's able to manage a lot of that, we would be looking at outpatient. If they show some degree of difficulty, intensive outpatient might be a little bit more appropriate. And if they're showing, pretty significant difficulty, PHP would probably be the level of care that we'd be looking at. Again, if they're showing a great deal of difficulty, as well as some medical instability or some medical concerns, then that residential or inpatient level care would probably be more appropriate. So I'm skipping a little bit of some of the criteria because I know it can sometimes be a little bit of a bore. but I also, I think if you've got access to a website and things like that, I can also share this with you just so that people can actually take a look at it. It's something you could easily Google. If you're Googling APA level of care guidelines for eating disorders, it's readily available. It's not something that you'd have to purchase or anything like that.
Okay.
And so generally speaking, that's the guidelines that we use at ERC. But as I mentioned, kind of when we were first talking, the APA doesn't really include a lot of those loss of control behaviors that you see in binge eating disorder. So I want to spend a little bit of time talking about binge eating disorder, as well as kind of getting familiar with what those level of care guidelines look like as well. But I don't know if you had any questions on kind of anything that I said there just a moment ago.
No, I don't have any questions yet. I think that was a really great overview and needed, because as clinicians, we need to know what we need to be concerned about with our clients and patients. So that's really helpful to know. Yeah. And we will go ahead and we will link the APA guidelines to the show notes so people can find it easy. No, not a problem. Yeah. So go ahead and talk to us about binge eating disorder.
Yeah, so binge eating disorder, the thing that really separates it from bulimia nervosa is the fact that those compensatory behaviors are not occurring. But a lot of the diagnostic criteria is pretty similar. So an individual that's engaging in binge eating behaviors for a duration of time that's over 3 months and at least once a week would qualify for that diagnosis. And a lot of times we get individuals that aren't super familiar with eating disorders that, they make comments of like, well, isn't binge eating something that everybody does? Or that looks a lot like, things that I do. And there are psychiatric and psychological components to a binge that might separate somebody who overate at, let's say, Thanksgiving time versus somebody who is showing a significant amount of distress around it. So clearly that would be one of the criterias, that they are distressed or impacted by that binge eating behavior specifically. You might see somebody has a lot of shame around eating in that manner. They might eat in secrecy or kind of alone and just sometimes even hide food from others that might be around them. They might eat rapidly fast to the point where they are eating beyond the point of being full. And so when we're looking at binge eating behavior, we really want to make sure that they're also showing some of those symptoms as well. Eating Recovery Center, not only are we looking at the behavior of binge eating, but we are also looking at any behaviors that demonstrate some type of loss of control. So anything from somebody emotionally eating, but maybe the portion that they were eating was reasonable, to somebody who had like a subjective binge where the type of food was something that they normally wouldn't do, just somebody maybe who is overportioning on their plate, but it doesn't quite meet that criteria of binge eating. So we're really going to take a look at all of that. In our treatment facility, we take a look at all eating disorder behaviors as if they're on a continuum. And one end of the continuum is that over-controlled eating, and the other end of the spectrum would be that loss of control eating. And so we're separating individuals based on kind of what their primary symptom is, and then making sure that we're implementing interventions that match those different symptomology. So, like I mentioned before, the APA guidelines are not super consistent with the diagnostic criteria of binge eating behaviors. As I mentioned, weight is one of the criteria, and weight is not something that really is a part of the criteria for binge eating behavior. Some of the other behaviors are not going to be relevant as well, like purging behaviors is not part of the criteria for binge eating as well. So Eating Recovery Center has developed some guidelines specific to our organization. So all of our assessment team uses this when they're taking a look at patients, and they use this criteria instead of the APA guidelines. So specifically, we also are taking a look at medical status when somebody is admitting for a loss of control type eating behavior. And the same would be true. Anybody who is medically stable, generally speaking, some of those lower levels of care, such as outpatient, IOP, or PHP, would be appropriate for them. Anyone who is demonstrating some of those same criteria that we see for the more restricting type of disorders would be relevant, but there might also be other components that we need to think about as well. Oftentimes, and this is not always true, but oftentimes someone with binge eating disorder also has some comorbid obesity that goes along with it. And so maybe something like type 2 diabetes, some kidney functioning is kind of impaired in some kind of way. So disorders that go along with those, we would want to make sure that they're pretty well managed as well. So if someone came in and they're really poorly managing their type 2 diabetes, it might be more appropriate that residential inpatient is the level of care that they need. Because they need a lot more medical supervision and a lot more support around kind of structuring the medical aspect of what they're dealing with, in addition to the behavior of binge eating. So that might be one of the differences that you'd see, is that we're really taking a look at some of those co-occurring medical diagnoses and just making sure that they're also stabilized as well. Suicidality, that's part of the diagnostic criteria for binge eating disorder, and it also is pretty consistent as well. So that's one just maybe to look at also. And then we look at the recovery environment and the amount of stress that somebody has in their recovery environment. One thing that we know with our binge eating population, and it's not always true, but a lot of the patients that we serve, they might have comorbid mood and anxiety disorders. They might have some comorbid substance use disorders, and maybe a lot of trauma that's going on as well. And so the amount of amount of distress that's in that environment kind of related to those things we really want to take a look at. So if somebody, for the most part, has a fairly stable environment, IOP or outpatient services would probably be pretty appropriate. If maybe there's some serious legal issues, school issues, work difficulties, some kind of impairment going on, then PHP would be a little bit more appropriate. And if there's a very severe disruption to family and social situations, then residential and inpatient services might be more appropriate. And then along with those co-occurring disorders that we see oftentimes with binge eating disorder, it really kind of depends upon how well they're managed. But if somebody is demonstrating, for example, let's say someone has a major depressive disorder in addition to their binge eating disorder, we would want to make sure that we're taking a look at how well managed their depression is. And if it is also pretty highly unmanaged, a higher level of care is probably more appropriate for them. So if we're seeing at least one comorbid disorder, we're going to recommend something like PHP and residential services. And if something is a little bit more primary, such as substance use disorder, then it might be that that individual needs to manage their substance use and then return to eating disorder services once it's managed.
Okay.
We take a look at functional impairment as well, not just the environment, but the impairment in the environment. And then eating disorder behaviors. So that would be the frequency that we're seeing those binge eating behaviors in particular. But again, at ERC, we take a look at all loss of control behaviors. So really any of those, the frequency in which they're occurring, we would want to take a look at. So generally speaking, that is the criteria for binge eating disorders. Again, I can also send that information to you as well, and make that readily available for anybody who is working with somebody in the binge eating population, but just isn't quite sure if it's something that's doable in the outpatient setting, or maybe they might need a higher level of care.
Okay, great. Yeah, we'll definitely put that in the show notes as well, because it's important information. Well, this is so interesting. I'm like, I love doing these shows. I learn so much. So thank you for going over all that. I know that it is a lot to kind of take in and to understand the different levels of care, the different types of, what the guidelines, all of that. It's so, when we think about treatment for binge eating disorder, can you share what treatment looks like for those who come to your? Okay, great.
Yeah, so I might start by just talking about PHP because that is the most intensive that we do here.
Mm-hmm.
And that's probably the one that people might be most confused about or what it looks like. So I'm going to maybe talk about what a typical day might look like, as well as the interventions our therapist would utilize with a patient in PHP. So a typical day, a patient comes in the morning and we check in with them. We want to know if they engaged in behaviors the night before. We want to know if they're experiencing any SI that day or over the night time. We want to know if they're experiencing any physical symptoms. So we're just checking in the morning. And during that morning time, we're also doing weights and vitals a couple times during the week, because we're not necessarily medically managing them, but we want to make sure that we're monitoring them and they're not needing a higher level of care. So weights and vitals are done pretty regularly with all of our patients. And then a patient, right after that, they'd go into our breakfast time. So most of the rest of the day is a flip-flopping between meal and snack times and some type of therapeutic or psychoeducational group. During the time that they're there for PHP, clinicians might pull them out for their individual therapy session, their family therapy session, a nutrition appointment, or to meet with our psychiatrist. So we do have a psychiatrist that's on staff, and she meets with all of our patients. And she really is the person that kind of makes that diagnosis, but she's also monitoring them to make sure that they're not needing a higher level of care, monitoring them to make sure that she's not needing to coordinate with the physician about some type of intervention that needs to occur. And also providing medication management if needed. Some of our patients are not on medications, but a good chunk of them are. So a good portion of the appointment that she has with them is really just taking a look at those medications. So that would be kind of like a day in the life of a PHP patient. When they sit down to meals and snacks, the support that the staff are offering is pretty structured.
Yeah.
So it's not that the patients come in, they eat, and then they leave and they go to group. We're observing and making sure that they're completing those meals and snacks. If a patient is unable to complete something, then they're expected to supplement with Boost Plus. Other eating disorder facilities out there, they probably also have different supplements that they use as well. And we're just making sure that they're getting in the energy needs that that the dietitian has established. Sometimes, though, we've got patients who they might be refusing that, which might indicate a higher level of care is needing if they're not able to even kind of utilize the support that's available. And sometimes a patient's still able to do the meal, even though they're struggling. And that's where our staff step in and they're providing empathy statements. They're reminding them to use their coping strategy. They might be offering some kind of different coping strategies available to them. And so they're kind of nudging them along. They might be providing feedback to the patient throughout the meal. So one of the things that they do is they point out any disordered eating behaviors that they might see. So if a patient is let's say they're eating baby carrots, but they're eating them with a fork, which isn't the most socially normal. They would probably prompt them and say, "Why don't you try picking up the baby carrot with your fingers?"
Right.
So part of their role also is just providing that in the moment feedback to normalize their eating behaviors at the table.
Interesting.
In the binge eating population, we do separate things out because the way that we're prompting them and the expectations that they have at the table are much different. We're not necessarily expecting that they're completing everything on their plate. They're trying to get to a place where they are not feeling a loss of control. And so if we're pushing them past that fullness point, we would almost be encouraging them to engage in behaviors. So somebody in that particular milieu, they do need to complete a portion of their meal, but at a certain point, if they still have a few things left on their plate, we're not necessarily prompting them to finish that up. Another difference is some of the behaviors that we're giving feedback about are completely different. So oftentimes we see in the more restrictive type disorders, they might have really, really slow pacing. So they're trying to extend that meal out so that hopefully they don't have to finish it. Mm-hmm. And in the binge eating population, or those that maybe struggle with loss of control issues around eating, their pacing might be really rapid. And so we're maybe prompting them to slow down. Why don't you set your sandwich down for a little bit just to kind of help slow down that pace. So the support probably looks similar in some ways, but the content is a little bit different. So meal support, again, is one of those treatment interventions that's provided. All of our staff are somehow involved in observing meals and snacks. So here at ERC, we have dietitians on staff, we have therapists on staff, we have behavioral health counselors that are kind of like direct care staff. They're on staff, in addition to many, many other staff members. And those folks, everybody on the treatment team really is taking time to observe some of those meals and snacks so that therapists know from their own observations what's going on, as well as the dietitians, as well as the behavioral health counselors can really help support them as well. So in addition to providing that meal monitoring and support, some of the interventions that we might use in the groups, in our groups in particular, we're providing a lot of psychoeducation on topics that they struggle with. So that might be something like boundaries. It might be things like finding different coping strategies. It might be things such as body image. Some of the more therapeutic type groups that we use are DBT, RODBT, ACT, CBT. And then we also have some caregiver groups that we utilize as well, because we know that if we can involve the family members, that our patients are going to be a lot more supported when they are returning to the outpatient setting. So the family-based therapies that we use are emotion-focused family therapies. So we're providing some of the skills that are in that particular treatment to our caregivers. And for us, caregivers could be anybody. Sometimes we see that caregivers are mom and dad. Sometimes they're grandma. Sometimes they're, a boyfriend or a husband. Sometimes we see that a roommate's coming in and they're supporting a patient. So we're really, even though we're using the term caregiver, we're really just talking about any loved one that is with the patient a good chunk of time and might have to provide a little bit more support when they're at home. So in the individual therapy sessions and the family therapy sessions, the interventions that the clinicians are using are some of those interventions that I just mentioned. They might be using more DBT type stuff or radically open DBT, sometimes CBT. And then at ERC, when we very, very first started, we were very focused on doing acceptance and commitment therapy. We've expanded since then, but ACT really is a part of just our culture here. So we utilize that with all of our patients. And RODBT and DBT is oftentimes used a lot with our patients because we know that the eating disorder symptoms function to manage their emotions. And RODBT and DBT really has a pretty big emphasis on emotional regulation, as well as opening up and being a lot more flexible. So depending on kind of the patient, they might need to identify different coping strategies to manage their emotions. And both of those different therapies can be pretty effective with that. Cool. And then CBT, it's shown to have a lot of evidence base with the eating disorder population. We oftentimes will use it a little bit more in the adolescent population because it is really concrete and it's easy for them to learn. And family-based therapies is another thing that we're doing in our individual and family appointments, especially in the adolescent anorexic population. We know that FBT is the treatment of choice or the evidence-based treatment that shows the most efficacy with that population. So we're doing standardized FBT with a lot of our patients. And depending on, sometimes we get adult patients where we're doing FBT with them as well, depending on their needs. If it is an adult who maybe they're in their sophomore year of college, they're still living at home, they're pretty well dependent on mom and dad still, it would make sense for us to use an intervention where, families kind of stepping in and providing a little bit more of that support. Mm-hmm. Mm-hmm. So those typically are some of the treatment interventions that we're using a lot of the time. And another one I didn't mention is exposure and response prevention. So we do what are called ERPs with our patients anytime that they're on a pass, or sometimes maybe they might even do it here in the treatment setting itself. And so when they come in, they're learning about what their symptoms of anxiety look like. They're creating a hierarchy of their fears around eating or around social aspects of eating or whatever it is that's going on. Some of our patients who have avoidant restrictive food intake disorder, maybe some of their fears are more about choking and, other fears kind of related to that. So it might not necessarily be about the food content itself. It might be other aspects of eating. And so once they've created that hierarchy, then they work along that hierarchy then and do those ERPs. And again, sometimes they're doing it more independently where they're doing it on a pass. And sometimes they're doing it with the support of treatment team members, kind of depending on where they're at in the treatment process or depending on how difficult they anticipate that different exposure to be. Our philosophy around kind of emotion regulation is just, we're not necessarily trying to eliminate your anxiety. Anxiety is a really powerful emotion and it is there for a reason. It's our body's way of communicating that we're uncomfortable or we're sensing danger or something along those lines. And so we really want patients just to regulate that stuff a little bit better, as well as get more comfortable with distress because it's normal. Mm-hmm. And the more comfortable you are with distress, the easier it is to move in the direction of your values, which acceptance and commitment therapy, we're really kind of, preaching value-directed living as well. So those are some of the treatment interventions that we're using here.
Wow. This is great. I mean, I'm just thinking about when I was in private practice and I had a handful of clients that were struggling with eating. I don't know if they were, the diagnosis, they fit the criteria, but I know a lot of women that I worked with, they struggle with disordered eating. And I talked about that on one of my episodes, the one that you were referring to earlier about disordered eating in our culture. And so how do you, when you think about disordered eating and you think about your patients that are coming in, at what level is there like a limit to, or like a spectrum of what is kind of, what's normal and how do you know when disordered eating becomes a bigger problem? I guess that's what I'm trying to ask.
Yeah. So I think one, we would take a look at functional impairment and intensity of behaviors.
Okay.
That's probably the two main things. But then again, you're right. Like a lot of people that are entering treatment, some of their ideas around eating, sometimes their ideas around movement, they're not very normalized. And so even those individuals, I think, could really benefit from mental health treatment of some kind. Not everybody necessarily is going to need a higher level of care, but somebody who, let's say the individual who has been on diets their entire life or a good chunk of their life, and really they're not demonstrating any behaviors such as excessive exercise, purging behaviors, any binge eating behaviors, but there's this strong attachment to being a certain size. They look at their self-worth by their body shape or their weight. I think that person could benefit from treatment. And then again, when it gets to that place where they're demonstrating impairment in their life and the intensity, they're engaging in behaviors, that's the point at which maybe a higher level of care is needed.
Okay.
And it's not to say that somebody who is, let's say, excessively exercising it, but they're doing it a little less frequently than the diagnostic criteria, they might not necessarily need, high level care, but they probably still need treatment at that point.
Okay. That's great. That's good to know and to think about. And when you think about clinicians out in the field, the folks that you partner up with or refer to you and vice versa, what are some things that you want them to know about when somebody's discharged from a program?
Yeah, so at ERC, like I mentioned, our providers really truly are a part of our mission statement. Like if I were to read it off to you right now, providers are literally one of the words that's in it. And so we are including our providers in the entire treatment process when somebody's in PHP and IOP, just to make sure that they know where a patient's at, the goals that they've been working on, the treatment interventions that have been utilized. And so they can kind of just pick up where things were left off. So when a provider refers to us, we'll have communication with them in the first 48 hours. We want to make sure that our case managers touching base and just making sure that they don't have any certain needs or anything that they've got questions on. Our clinicians will touch base with them as well and just kind of get some insight about what was going on. And then we provide treatment plan updates to them every 2 weeks if they're an IOP, once a month. But if a provider is requesting a little bit more often than that, we're more than happy to do that. Or if a provider is requesting documentation that we might not normally provide, we're also more than happy to send that on. Of course, as long as we're getting consent to do so.
Yeah.
And that's another thing too, when we're working with a patient at the very start of at admission, we're letting that patient know your provider is a part of your treatment here. And we really do have to have those ROIs in place in order to really communicate with them. It's kind of a limit that we're setting with them, is that their providers have to be involved.
Okay.
And then throughout that conversation, so our treatment, we make sure that our providers are writing their treatment plans in a way where providers really understand, like, this is literally what was done this week. This is literally what was done the next week. And so eventually when they return to them, they know right where to start off. And we're also, oftentimes we're emphasizing to our patients that even when they eventually get to the point where they're in IOP services, that they really should start working with the outpatient provider at the same time so that there's that smooth transition. And we also have coordination. We might do some joint sessions with the outpatient provider just to make sure that that the outpatient provider feels supported and kind of knows what's going on.
Yeah, that's really nice.
Yeah. And I think, that's the standard that you're going to see at a lot of facilities that do eating disorder services, is that we just really want to make sure that when a patient returns to their home or their living environment, that they really have the support that they need. And also something that we would really want providers to know is that if they've got somebody in their practice that they're working with that they're really not quite sure if it's appropriate for outpatient or if they need to move up to a higher level of care, part of my role is also just connecting with providers too. And if somebody calls me up and says, "Hey, Brandi, I've got this patient, I'm not really sure what to do," I'm going to give my insight about, yeah, it sounds like this one might need a higher level of care. Or, you know what, maybe if you move in this direction, like that might be someone that you can still support in the outpatient setting. So that's something that's offered through our services, is just that ability to consult on cases and to feel supported even when they're not in treatment with us.
Oh, that's really nice that you offer that. I mean, and that's so helpful. So therapists out there, if you need to consult, if you're wondering about, your patient, that really is a wonderful service, because sometimes you're just like at a loss. You're like, that things, because they can just decompensate pretty quick, and you need to have, sometimes you just need that clinical consult. So it's really nice of y'all.
It really can feel like you're on an island when you're in the outpatient world. And a lot of times you're not seeing the patient 8 hours a day like we're seeing in the PHP. So you don't know if the patient's being honest about behaviors. You don't know what other things might be going on. And that can be really difficult. You might see that, maybe they are and they're dropping weight, but at the same time, they're telling me that they're eating all their meals and snacks, or maybe they're overemphasizing some behaviors, but they're not telling you about other behaviors. And so, we really want to make sure that providers in the outpatient world just feel like they've got a sounding board to kind of talk about some of their cases as well.
Yeah. Yeah. That's really a generous
Yeah.
benefit. So thank you.
Yeah.
Thank you so much. Now, if somebody is listening in North Carolina, can they call and talk to you? Is that a...
Oh, yeah.
Okay.
Yeah. We serve patients. We really are the only ERC that is in the Southeast. We've got quite a few centers that are up in the Northeast, and we've got, and a good chunk of our centers are in Texas and then out West as well. So if somebody calls from, Atlanta, North Carolina, even Florida, we would be happy to just kind of talk about their cases with them and just let them know what, options they have to be able to better treat those folks.
Okay. Very cool. I know we initially were going to talk about avoidant restrictive food intake disorder. And when you and I originally connected, I was like, I don't even know what that is. So we've got just a little bit of time left. Would you mind talking a little bit about, I think you called it what'd you call it?
ARFID. Yep.
ARFID. Yeah. ARFID.
So basically it's avoidant restrictive food intake disorder, just abbreviated. It's a lot easier to say ARFID than it is to say that entire name. And ARFID was a diagnosis that was added to the DSM-5 when they updated it, along with binge eating disorder. And really the thing that separates it from anorexia is that somebody with ARFID, they don't have this misperception of their weight or shape, and their intent is not necessarily to lose weight. It's more so to eat in a certain manner, or it might be that they have fears about eating. So generally speaking, the ARFID patients that we see, they probably fall into about 3 different categories. I would say one category would be that somebody's coming in and they have swallowing issues of some kind, whether it's a fear of choking, whether it's they literally have a physical kind of comorbid situation that's going on where they can't swallow very easily. So that would be one type. We also see that sometimes patients come in and they have some kind of traumatic experience around eating or around swallowing that makes it really difficult for them to eat. And we'll treat them in a very trauma-informed way. And then the third category would be somebody that more so fits like in an orthorexic category. Orthorexia is kind of a term that we throw around in the eating disorder field that essentially is somebody that's trying to eat perfectly. So they might be the type that is eating only organic food, or they're eating only, a certain way. Maybe they're only eating, food that was sourced locally. And the difference would be that the individuals that fall in this category, they've taken it so far that they really have lost a portion of their weight, or they have fallen off kind of the growth charts, and they're not in the same developmental trajectory that they were before. So those would be the three categories of ARFID that we see most often. And the way that we treat them, like I mentioned, with the folks in that second category, is a very trauma-informed care way. We might be using similar interventions. Oftentimes with all three of those, we're emphasizing exposure response prevention with them, because we know that the more and more that we're exposing them to the situations, really what's kind of around all of that is a fear of eating in some kind of way. And the more that we can expose them to the things that they're fearing, the more that we can reduce some of the behaviors that we're seeing.
Okay.
So that's a little bit about ARFID. And a lot of times it's thought of, I think, in the community as maybe picky eaters, or, adolescents that just aren't eating. We do see it a lot in the adolescent population, but we also do see adults with ARFID. So it's beyond picky eating. I would say most often, if you're seeing someone kind of with those three issues, it probably is a diagnosis of ARFID.
And, with today's access to all kinds of different diets and nutrition programs, it's hard to know sometimes but I think you just have to go back to, is the behavior causing the loss of weight, or the interfering with activities, that kind of stuff. Is that how you would kind of look at it? If
it's let's say somebody is like that third category, somebody that is trying to eat only organic foods that are locally sourced, and they are on a vegan diet, let's say. They've restricted the amount of foods that they can have so much that there's not a lot there.
Right.
So some of it too is providing them some nutrition education about what a normalized eating plan might look like. And then, of course, exposing them to things that might be outside some of that. In regards to the debate out there of, do you take patients that have, that are trying to practice a vegan diet? Do you take patients that are trying to practice vegetarianism? And that's a little bit of a difficult, question to answer. In regards to vegetarians, we really want to assess what's the function of that. If it truly is for ethical purposes, we're going to honor that patient and kind of make sure that we're honoring their ethical practices. A lot of times, though, we can see that there's fear behind it, and we're going to let them know that we're probably going to expose them to food items that are outside of that. In regards to somebody coming in with a vegan lifestyle, again, we want to assess as well, kind of what's the function of that. And we also want to educate them too, that it's going to be extremely difficult for them to meet their nutritional needs and to be able to stabilize themselves nutritionally without flexing a little bit.
Right.
And again, that's a conversation. We might just kind of hop on a call with our outpatient team and just jointly talk about, that decision together. And sometimes it might be that our assessing clinician kind of talks about that with them. But it really is difficult to do eating disorder treatment when you're trying to follow a vegan lifestyle.
Yeah. Vegan lifestyle is hard enough as it is. I can't imagine.
Yeah.
Trying to throw, really, it's not easy. Woo.
It's not. And oftentimes what we see is most of the individuals that are coming in that are practicing a vegan lifestyle, there really is some disordered eating that's behind it. So we are going to kind of expose them and shape that.
Yeah, I agree. And I think as my years of doing clinical work around disordered eating, when I would talk with someone who is adamant about following the vegan lifestyle, I'm like, let's talk more about that. And I'm not judging it. I'm just I want to help the person, because it's like, sometimes you're just not doing yourself a favor. You think you are, you think you're being the true health, advocate, but if it starts to impair your health, you have to.
Then how healthy is it? Yeah. Right. And what people may not notice is there's so much information out there in regards to nutrition, in regards to diets, in regards to just food in general and eating. And it's hard to filter through what information that's out there is well researched, what information out there is practical to use, and what information out there is not well researched and not well supported.
Yeah.
And that's hard to do.
Yeah.
Most individuals, they probably are not going to do that work of looking up research articles on various diets and taking a look at the source of where they're finding that information. And so it's better really just to consult a professional when it comes to those types of questions.
Yeah, I agree. I mean,
Uh,
and I'm just going to flip that a little bit and say it's important to, talk with a mental health professional if you're wondering about a mental health diagnosis, or, I'm just going to, it's a similar idea. So, always talk to a dietitian, a registered dietitian. They've got the education, they've got the license, and if they don't know, they can refer you to somebody that they know that's their specialty, and that's kind of So I just had to get on my soapbox just a little bit there, because like you said, there's just so much out there right now. It's overwhelming. Where are you getting your information from, and how? So I totally get that, and I appreciate you saying that, because I think that's really important. Because a lot of times people they're hiding behind their diet, they're hiding behind their issues and calling it veganism, or they're calling it, whatever food lifestyle plan they're following. So, and there's not a one plan fit for everybody. We're all made so uniquely. So this has been really enlightening, and I'm so glad that you came on to the show and gave us, all this information on ERC and binge eating and ARFID. Did I get that right? Yes.
Yep, ARFID. Yep.
I definitely learned something new today. I was like, what is she talking about? When we were talking earlier, like okay, I just won't say it again. So if people want to, or if clinicians out there are wondering more about how to reach you, what's the best way to find you?
Yeah, so the best way probably would just be to email me or call me up. I can give you that information so that you've got it on your website as well. But my email address is Brandi, and it's spelled Brandi, Stalzer, Stalzer, at eatingrecovery.com. And then also, if they're wanting just to explore Eating Recovery Center a little bit more, I would just, direct them to our website, which is eatingrecoverycenter.com. There, they can find a wealth of information about eating disorders. They can find a wealth of information about the different levels of care. And then there's a page where they can kind of get familiar with the Greenville site here and just get an idea of the providers that they're going to be seeing, as well as kind of what services look like.
Awesome. And I appreciate you doing that. And we will definitely link to the show notes, all your contact information. Now, I know we were talking earlier, sometimes you guys make your way to different parts of the state and do some of these contact hours for folks.
So ERC, again, providers are a big part of our mission. And so it's important for us not only to provide, case management, to make sure that they're informed what's going on with their patients, but also to provide some continuing education to providers that are out there. I am in the middle of planning it right now, so I'm not exactly sure some of the details, but I believe I'm going to be doing a continuing education event down in Columbia sometime in November.
Oh, cool.
And sometimes we'll bring in different researchers, different providers that we have across the ERC system. So we have Allison Chase, who is the regional directing manager in the Texas area. And she's going to be coming probably sometime next year, talking a little bit more about EFFT. I believe Ralph Carson, he is a registered dietitian and a very, very knowledgeable man, will be coming in. And to be honest, I'm not entirely sure what his topic's going to be, but he'll be coming in kind of next year as well. And so also another thing people can know is if they've got an agency or if they're part of a group where they just really want to learn a little bit more about eating disorders, they're welcome to call me up as well. And we can explore different ways that we can do some type of event or some type of continuing education with the group that they're with or the organization that they're with.
But this has just been so great. Thank you so much. And my hope is that we will be able to provide 1 hour of continuing education contact hours for this episode. So you guys continue to check back on the website. You will see it up there. If it, I'm at the point where I've been approved for 2 courses and I'm getting approval for another one. And then after that, I can apply for like the blanket approval for South Carolina. And that is the goal. And my hope is we will be able to add this one to the course list that people can get 1 hour of CE continuing education. So thank you, Brandi, so much for being here. This has been so helpful. And I'm excited to put this information to use. So thank you so much.
Yeah, no problem.
Well, that wraps up another episode of The Therapy Show with Lisa Mustard. I know there are hundreds of thousands of podcasts out there, and I'm thankful you've chosen to listen to mine. Be sure to visit lisamustard.com to access the show notes and discover more fantastic content. And I'd be grateful if you subscribe to the show. Thank you.